Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me for the whole episode today, he's not just my co-host, he's also our guest. It's Frank Gaillard.
It's a genuine honour to be invited onto the podcast.
Yeah, I mean, I've been wanting to have you on the pod for a long time. It's an absolute dream come true. I'm such a big fan, particularly of your movie reviews. No, instead of the usual intro followed by a pre-recorded main segment and then an outro, today we're going to do this whole thing in one go here, Gaylord. We're doing it live because this month you've just released the fourth, I think, installment in your series of Radiopedia brain tumour courses, and this one is all about posterior fossa tumours.
Yes, indeed. It is the fourth one. The fourth one of what was going to be a single one, and that was going to be released maybe 3 years ago by Christmas, and I'm now 80% of the way through. Maybe there's one more, but it's a direct continuation of the first three, which were on diffuse gliomas, enhancing supratentorial tumours, and epileptogenic tumours. Theoretically, there is one more, maybe two, covering extraaxial and intraventricular tumours. But to be honest, I think these four taken together already form a really comprehensive course, not just on brain tumours, but a lot of general MRI principles as well.
It's the series that may never come to an end.
That's right.
A couple of episodes ago, we had Skalski on the podcast, and I played a series of audio clips from his new musculoskeletal calcifications course, and that worked well. And I was going to do the same for this new course of yours, Gaylard. So I got in there, I watched all your videos. It was fantastic. But as I was going through, I found that they're very visual. I couldn't really just select out audio clips and play them. So instead, what I've done is I've pulled out some of the key points that you've written that appear below each of the video lectures in your course. And the plan would be for me to read out some of those and for you to expand upon them in audio form for our listeners.
No, that sounds good. But before we start, I did my homework and I came up with a couple of April Fool's idea.
Ah, yes. Good boy.
And you know how we're always making changes to the site, which in principle are meant to make the site better, but sometimes make it explode and completely shut down, as happened recently. Anyway.
We had our longest downtime ever the other week.
I know. Anyway, in that vein, I thought a few April Fool ideas that could work would be kind of new feature focused. So how do you like the idea of moving Radiopedia from being freely accessible, all the articles and cases to everyone, to putting it behind a paper finding paywall? So the basic plan, which would still be free, would be limited to only normal scans and foundational articles. And then we would rejig our supporter plan so that silver supporters could get to see cases and articles with incidental and clinically irrelevant findings only. Then gold would get common and obvious pathologies. And then if you wanted to actually unlock everything, you'd have to become a radium supporter.
Oh, yeah.
That would work.
Well, along similar lines, how about you only let users scroll through, when they scroll through a stack of CT or MRI, they only get 3 images per stack, and then it says, boom, boom, you need to upgrade to see the whole of this study. That is actually what most websites would probably do, to be honest.
Yeah, or 1,000 images per month, and then above that, you need a subscription.
Mate, we could alienate people, a lot of people, very quickly with those ideas.
The other idea was to add a new mode for the website called Radiologist mode as an option. Of course, this is only for logged in users, and you'd toggle it on. And when you did that, it would hide clinical presentation, pathology, and treatment and prognosis from all the articles and replace the findings text for cases with classics like features are non-specific and clinical correlation required, or additional imaging with PET CT recommended, or repeat imaging in 3 months or something.
I like it. Even if you just took the radiographic features section of every article, which is like the most popular section that people often go to, and for the April Fool's Day, just replace it with findings are non-specific and clinical correlation is required, with maybe an expand for more details button. And when you expand it, you actually get the details, plus a little Rickroll video. Murph, who helps us produce this podcast, sent in a couple of suggestions. So he really liked the idea of the fake merchandise, but he was wanting to jump on board more with this trend of celebrities having their own alcohol brand. You know how like
Oh,
Yeah, they've got their gins or their tequilas. So he was thinking, yeah, we could announce the Radiopedia distillery, the Radiopedia gin for the
I
world.
think that would be outstanding. What could possibly go wrong? Then we could have glassware to go with it.
Hmm.
Radiopedia cocktail shaker. The
I'm
mind
still,
boggles.
I still like the capture idea. I still like that. If we could
Yeah.
get some little pop up just to mimic a capture, even if it wasn't nicely encoded to do everything like a capture does, but just something that stops people and makes them think for a second.
And as soon as you click it, that's when you get the Rickroll.
Yeah. Although we would be sending a lot of people
It's
to a Rickroll if we pop that in front of everybody entering Radiopedia for the day. Anyway, we better kick off our chat about posterior fossa tumours, Gaylord, because that's what we're
yeah.
actually here for. So your course begins with an introduction, pretty standard. That's where most courses begin. But instead of talking about brain tumours or posterior fossa tumours at all in that introduction, Gaylord, all you seem to do is talk about hydrocephalus and arachnoid membranes.
Yes, I know. But there's at least as much non-tumor, non-posterior fossa content in this pathway as there is anything actually related to the title. And I can't resist going off on tangent, not just because it's, at least for me, more interesting than just talking about the core concepts, but because I think actually these kind of tangents end up tying everything together in interesting and unexpected ways and allow you to understand things better.
But can you even call it a tangent if you never got on track in the first place? Going off on a tangent in the introduction video.
Speaking of track, do you know when to use track CK versus tracked CT?
Well, I think I roughly know.
Well, we've tried to clarify this on the website recently.
Yeah.
It's not that obvious. So, a track is a thing that you create surgically, like a needle track,
Yeah.
whereas a tract is like a linked group of organs, like the gastrointestinal tract or white matter tracts.
Hmm.
So, if you shove an EVD through the brain, you leave a track and it might
Ah.
cut through some white matter tracts, with the exception being surgical tract, which is CT. So the whole thing is, as we expect with English, and we'd be disappointed if we ever came across an example where this wasn't the case, a complete mess.
So when I say that there's evidence of a previously removed EVD tract or something like that, I'm wrong. I should say
Yeah,
track.
you should say
Mm.
track. That's right.
Well, there you go. Yeah. All
There
right.
you
Well,
go.
your tangent has taken us off track, but I have actually learned something, so that's good. But let me get things back on track, CK.
Yep.
So there's one key point from your introductory ramble that I'll read out here because I've got to read out something from it. So it says clinical presentation is generally not helpful in narrowing the differential diagnosis when dealing with posterior fossa masses.
Yes, well, this applies anywhere really that mass effect is the dominant process through which patients clinically present. So the spinal cord is another example. Posterior fossa masses produce effects by compressing the cerebellum and brainstem and eventually causing hydrocephalus. And the way patients present is dominated by these effects, regardless of the underlying cause. And so,
Mhm.
in many ways, this is one of the nice things about neuroradiology. The history that's given to you on the requisition form, or the lack of history, often doesn't make that much of a difference compared to, say, I don't know, chest radiologists that have to know everything about patients' hobbies and
Mm.
where they've traveled and whatever else they do. We can just be told headache or confusion or ataxia. Who cares? Let's just look at the pictures and we'll tell you what's going on.
But the funny thing is that the radiologist, neuroradiologist, is more likely to tell you a good differential diagnosis about what it could be, whereas the chest radiologist, even with all that history, is still more likely to say non-specific.
Yeah, that's right.
All right, let's move on now to talk about ependymomas
Mhm.
specifically, Gaylord. So these are glial tumours with ependymal differentiation. I'll read two related key points about ependymoma from your list here. So you write, ependymomas have been reclassified in the WHO 5th edition with a greater emphasis on location and molecular markers. And posterior fossa ependymomas are divided into two groups, A and B, which are distinct entities.
So, yes, this is a big improvement in the WHO classification compared to previously. Now it's just divided into, well, we've got subependymomas and mixopapillary ependymomas that remain their own separate diagnoses. But the bigger group of ependymomas is now divided anatomically into supratentorial, posterior fossa, and spinal. And the posterior fossa ones are then further divided into group A and group B. The reason this is a nice simplification is not just that it's easy to remember, but also that it highlights the fact that really these are separate tumors. These are not the same tumor that occurs in the fourth ventricle that happens to occur in the lateral ventricle. And in fact, supratentorial ependymomas tend to be parenchymal, not intraventricular. So it simplifies, I think, the way that you think about it. The prognosis is different, the imaging characteristics is different. And something you said just before you read out those key points was that they are glial tumors with ependymal differentiation. And I think that's a really key point with all glial tumors, is that when you talk about a renal cell cancer, you're talking about a kidney that has renal cells and, they become cancerous, or a colonic adenocarcinoma. When you talk about an ependymoma, these aren't tumors necessarily that arise from ependymal cells. They arise from pluripotential cells and then differentiate to mimic, in some ways, particularly histologically, ependymal cells. And so that kind of explains in some ways why you end up getting parenchymal peripheral ependymomas in the supratentorial compartment where they're not related to the ventricles.
In terms of the imaging features, Gaillard, the group A posterior fossa ependymomas, that's the young children one, they usually arise from lateral recess of the fourth ventricle, whereas the group B ones, that's the adults, they usually arise from the midline floor of the fourth ventricle near the obex, and they typically appear heterogeneous on all modalities, right?
Yeah, and where these tumors arise, I must admit, I don't find that helpful because I find it hard to tell. Sometimes you see small tumors and you can see where they are located, whether it's laterally or further down in the midline, but often they're larger. And sometimes you can see a small amount of parenchymal high T2 signal from where you think they arise, but more often than not, you don't really know. But they do almost always appear heterogeneous on all sequences. They're heterogeneous enhancement, often patchy, fluffy, sort of ill-defined edges. They may have necrosis, they may have some areas of hemorrhage, they may have calcifications. So that is an important feature.
But probably the most important distinguishing feature, Gaillard, is your next key point here, which is soft plastic extrusion through the fourth ventricular foramina is a good, but not perfect, sign of ependymomas.
Yes, and plastic here does not mean plastic, the substance, or microplastics that you've eaten by consuming yogurt, but rather the sort of engineering term or material science term, meaning plasticity, the ability for it to deform. And posterior fossa ependymomas are apt to extend through the foramen of Luschka, particularly to a lesser degree Magendie, sort of extrude out, and it's been compared to toothpaste. And this is characteristic. It can be seen on both CT and MR. It's not perfect because you will be able to find other posterior fossa intraventricular tumors or even medulloblastomas that can kind of mimic this appearance. But it's just one more piece of evidence pushing you towards that diagnosis.
Now, the next key point I have here, we're going to kind of build more details around this as we move through, but I'll read it now so we can at least make a start on it. And that is, contrast enhancement and diffusion characteristics are complementary in distinguishing between medulloblastomas, ependymomas, choroid plexus papillomas, and subependymomas.
Yes. I mean, there's a lot in there, isn't there? And it's a shame that there's no single reliable feature. As you probably know, I follow up my cases pretty diligently, and I've been wrong many times, particularly with choroid plexus papillomas and ependymomas, which you think you should be able to tell apart really readily, and subependymomas to a lesser degree. But these tumors don't always read the textbooks and they don't do what they're meant to do. But if you combine contrast and diffusion, as well as morphology and some epidemiology, you can get pretty close most of the time, or at least you won't feel bad when you get it wrong. The reality is, though, that when you can't distinguish between them, you're usually looking at quite a sizable, heterogeneous, ugly looking tumor that could be a number of these different tumors. And so it's going to need to come out anyway. So I don't think I don't like the excuse of we shouldn't bother trying to get it right because it has to come out anyway. But it's okay to not get it right in these terms. You're not usually losing anything.
We mentioned choroid plexus papilloma here in that list, so it can in particular be a differential for ependymoma. And so I've got your key points for choroid plexus papilloma written here. The first is choroid plexus papillomas usually enhance vividly, but not always. And the main differential is that of a posterior fossa ependymoma, which are more common and usually enhance less vividly.
As I said, distinguishing between these two sounds easy, and the way that these tumours are described in textbooks makes them sound very distinct. In practice, this isn't always the case. But thinking back to the times that I've been wrong, if you're not sure because the features are overlapping, then go with ependymoma because ependymoma is far more common. Fall back on baseline incidence. And that's why having some sense of relative incidence of differentials or even absolute incidence is really important, because it's like cheating. It's a cheat code for getting it right most of the time without actually doing all the hard work.
You could say something like, this tumor most likely represents an ependymoma. However, given the strong contrast enhancement, choroid plexus papilloma would be a differential consideration, something like that.
That's right. Those are those well-crafted conclusions that are designed so that regardless of what the outcome, people think you knew it all along. It's a real art form to do that.
So the next point you've got here about choroid plexus papillomas is in adults, choroid plexus papillomas are usually in the fourth ventricle, whereas in children, they most commonly arise in the atria of the lateral ventricles.
Yes, and I think this is interesting because as a general rule, children have things in the posterior fossa and adults have tumors in the supratentorial compartment. And this is kind of the classic reversed example where children have it supratentorially and adults have it in the posterior fossa. And I think the reason for this is that the amount of choroid you have in the lateral ventricles when you're a child is much, much larger than when you're an adult.
Ooh.
And so there's just more cells there from which a tumor can arise, because unlike glial tumors, choroid plexus papillomas arise from the choroid plexus. And so having more of it gives you, all things being equal, more chances of it occurring where there's a lot of it there.
Let's move very slightly away from the fourth ventricle now, Gaillard, and into the parenchyma of the cerebellum to talk about medulloblastomas. So these are one of these small round blue cell tumours, which is actually helpful when you want to remember the imaging features. And like with the ependymoma, Gaillard, medulloblastomas in the WHO 5th edition are divided into some distinct subgroups.
Yes, and it's another example of where the classification is actually a little bit easier than before, provided you steer away from all the subgroups and subtypes, because then that's exploded. The key points is that molecular subtypes of medulloblastomas have different demographics, prognosis, and imaging appearances. And so being familiar with the ones where those features are different is important. And now that's reflected in WHO. So what we have is sonic hedgehog activated and WNT or wingless activated medulloblastomas, whereas before they were known as group 3 and then a separate group 4. These are combined under the non-imaginatively named non-SHH, non-WNT tumors. Or they could have just said MISC or other or stuff, but it's one of these things. And then each one of those has more breakdowns. But the important thing is, particularly with sonic hedgehog, is the one that I see most of the time, because that's the one that adults tend to get. And it's very distinctive in appearance. It's not a midline tumor of the vermis. It's located peripherally. It's heterogeneous. It often has some cystic areas. It often has some hemorrhagic areas. And you can usually make the diagnosis with pretty high certainty. The key here is the small round blue cell component. Medulloblastomas share similarities with lymphoma and pineoblastoma, for example, because when you look at the histology of them, they are made up of very densely packed cells, which are mostly made up of the nucleus, so blue. And as a result, they don't have as much fluid as other tumors, so they're lower on T2. There's not as much ability for fluid in the extracellular space to move around, and so their ADC values are lower. And the important thing here is that the ADC values are lower than normal brain parenchyma or normal
Mm,
cerebellum. Maybe not as low as a stroke, as an
yeah.
acute stroke, but you're still talking about, say, 600, whereas
Mm.
normal parenchyma would be about 750. And that's in the solid components. And if you find areas that are that low, you're unlikely to be looking at some of those other entities that you might be confusing it with, because ependymomas can be highly cellular, but they tend not to get quite that low.
A little bit analogous to glioblastoma and CNS lymphoma when you've got profoundly low ADC values.
Yeah, exactly.
That is a highly cellular lymphoma. You can get low ADC values in a glioblastoma, but it's coming back towards what the normal parenchyma is rather than, it kind of elevates your ADC up if you've got a low grade tumor.
Yeah.
And then as it comes back towards being a high grade tumor, you lower the ADC values back to what normal parenchyma is. But if it goes lower than normal parenchyma, you're really thinking small round blue cell tumors like lymphoma, or in this case, medulloblastoma.
Yep, absolutely.
All right, let's now deal with two other posterior fossa parenchymal tumours, and they're often considered together, these two, because they have a similar imaging appearance, that of a cyst with an enhancing nodule, so pilocytic astrocytoma and haemangioblastoma. And you have the key point, Gaillard, that goes some way to explaining why they actually might look similar. So you write, both pilocytic astrocytoma and haemangioblastoma have elevated VEGF, which is responsible for vascularity enhancement and cysts.
This is quite a bit of fun, actually, to have gone into it. And it's one of the best things about creating these learning pathways is these little research side quests that I go on. And it also explains why I have roughly a 1 hour per minute ratio of work to eventual content. But anyway, what struck me as I was trying to explain these two tumors that present kind of in a similar way is like, why should they look so similar? Why do they both have cysts? Why do they both have really vividly enhancing mural nodules? And it seems that at least part, or not the answer to that question, is vascular endothelial growth factor, VEGF, which is a powerful pro-angioneogenic factor. So it creates new vessels, but it also increases vascular permeability dramatically. And this explains the enhancement, because it's important to remember that most MR enhancement is due to gadolinium leaving the capillaries and entering the extracellular space and causing shortening of T1 relaxation time in the water of the extracellular space. So high T1 signal, rather than like on CT, where you actually visualize the contrast directly. So having leaky capillaries and allowing that gadolinium to leak into the tumor is why these tumors enhance so vividly. But that leakiness also allows water from your plasma to leak out a lot. And because that happens a lot, well, it's got to go somewhere and it can't all be resorbed. And so it often accumulates in a intratumoral or peritumoral cyst.
Mm.
And so you end up with this vividly enhancing nodule with a water fluid collection next to it or within it.
It is cool when you've got completely different histologies, but showing one similar growth factor is enough to make their appearance look the same. So while they can look similar, there are some clues that people might use to help favour one over the other in their differential, Gaillard. So do you want to summarise some of those clues?
Well, one of the biggest clues is age, because pilocytic astrocytomas mostly occur in children, but there is some overlap. We do see pilocytic in younger adults, say up to 30, 35, although more often than not, they end up not being classic posterior fossa looking tumours. They're more commonly supratentorial, near the midline, or along ventricular surfaces. And hemangioblastomas that are most commonly in adults, occasionally we also see them in younger patients, particularly if they're in the context of von Hippel-Lindau. So there is, some overlap. And there's quite a lot written about distinguishing pilocytic astrocytomas from hemangioblastomas on the basis of whether or not they have enhancing cyst walls,
Mm.
where pilocytic astrocytomas are said to have intratumoral cysts. And so the cyst wall enhances, it's part of the tumor and should be resected. Whereas hemangioblastomas tend to have peritumoral cysts, where the cyst is adjacent to the nodule, pushing brain parenchyma away, but there's no tumor cells in the wall of the cyst itself. I don't think it's quite that simple.
Mm-hmm.
I did a fair bit of reading around this to try and sort of pin it down while preparing this, then it doesn't seem that it's as clear cut as that. But I think there's enough there that if you see a lesion that has an intratumoral cyst or where there's obvious thick or nodular enhancement around the cyst, that
Mhm.
should push you towards a pilocytic astrocytoma. Whereas if you don't see any cyst wall at all, then that should push you towards a haemangioblastoma. The benefit of that is that it informs surgical resection as well, because if there's no enhancement, the cyst wall is usually not peeled off or resected, it's just left behind. But the best feature, if you see it, is the presence of prominent flow voids. It's a really strong indicator that this lesion is going to be a hemangioblastoma. The problem is in smaller lesions, they won't always have them. By the time you get a big tumor,
Mm.
like say a 1.5 or 2 centimeter nodule, then you would really expect to see big flow voids if it is a hemangioblastoma. But those smaller, earlier tumors are less likely to show that feature.
Now, there are a few entities we've skipped from the course here. You did a section on brainstem glioma and some mimics of brainstem glioma. And speaking of mimics, you also did dysplastic cerebellar gangliocytoma, so Lemaitre-Duclos disease. Anything you want to specifically say about those ones before we finish up with a discussion of extraaxial tumours in the posterior fossa?
Only that Lemaitre-Duclos disease is everyone's favorite, right? For some reason, it's such a popular tumor for residents and registrars to know about. I don't really know why, but it kind of looks cool, I guess. The main thing there is that the differential for it is not really other tumors, but it's predominantly cerebellitis or infarcts, I guess. So this is a situation where the presentation is actually really important. Unlike many of these other tumors, knowing that it's a kid who's had a recent viral infection or someone who's older who's presented acutely ataxic will really help
Mm.
you make that distinction.
I think it's similar with brainstem glioma or midline glioma. You've got the differential of, osmotic demyelination,
Mm.
MOGAD, or something else that's going on in the brainstem rather than tumors, because these ones are really, non-enhancing lesions typically. All right, so let's finish up here, Gaillard, with the extraaxial posterior fossa tumours, and specifically the two tumours that occur at the cerebellar-pontine angle are the ones you focused in on. So the vestibular schwannoma and the meningioma, both usually strongly enhancing masses and can look similar. So let me read your key points that appeared below the video in your awesome course. So it says, an understanding of the bony anatomy of the internal acoustic meatus is important in determining which nerve schwannomas arise from, which is, in turn, important for surgical planning.
Yeah, bony anatomy is going to get more and more important as our ability to resolve these tiny little structures becomes. This has already occurred really with routine, high quality, high resolution CT, but it's going to be even more pronounced with a wider adoption of photon counting CT, where the resolution is just insanely good for this kind of anatomy. And so being able to identify which canal is slightly widened if the tumor is going in it allows you to distinguish a facial schwannoma from a vestibular schwannoma,
Hmm.
but it can even allow you to distinguish a nervus intermedius schwannoma from a facial schwannoma because it will go out the front along the greater petrosal canal rather than turning back, those sort of things. So I think it is interesting. It does mean that you have to learn more anatomy that you either never learnt or forgot.
Yeah, it's like inner ear high drops,
Yes.
finer and finer knowledge of this anatomy that you thought was irrelevant back in the day.
You know more and more about less and less. Yeah.
Now, another point you've got written here is schwannomas arrive distal to the transition zone, which is located at some distance from the nerve root entry zone.
Yeah, so the idea behind transition zone versus nerve root entry zone is not as well recognized by many as I think it should be. And I know I went years before I understood that there was actually a difference between these two. And you usually encounter it when you're talking about trigeminal neuralgia, where impingement on the transition zone is where the nerve is particularly susceptible. And so, what's the transition zone? Well, it's the place where central myelin oligodendrocytes gives way to peripheral myelin Schwann cells. And in that area, there's relatively little myelin, and that exposes the nerve to external irritation by vascular loop compression, etc. Importantly, that transition does not occur where the nerve exits the brainstem. So it doesn't occur at the nerve root entry zone or exit zone, depending on whether it's motor or sensory nerve. But it occurs some distance from there. And how far is variable and depends on which nerve you're talking about. So the trigeminal nerve is usually within 3 to 5 millimeters of the brainstem, whereas the vestibulocochlear nerve, it's much more distant, like 15 millimeters or
Mm.
so. And so, well, it makes sense that you can't get schwannomas closer than that 15 millimeter or so from the brainstem because there's no Schwann cells there.
Yeah.
And if you think of all the schwannomas you've ever seen, they're always either intracanalicular or just at the porus acousticus. They're never tucked up right up against the pons. And that actually probably is helpful in that if you were to see a solitary little enhancing nodule right at the nerve root entry zone, it's probably not a schwannoma. And so you should be thinking, is this a CSF metastasis or something else, sarcoid, etc.?
Nice. Never thought about that. I'll read a couple more of your little points here, Gaylord. So schwannomas remodel bone, whereas meningiomas do not, but may cause hyperostosis. And larger schwannomas often have cystic areas, whereas this is uncommon in meningiomas.
Yeah, so unlike ependymomas versus choroid plexus papillomas, where you just have to accept that sometimes, no matter how hard you try, you're just going to get them wrong because they look so
Yeah.
similar. I think distinguishing schwannomas from meningiomas is something that you should almost never get wrong. The imaging features, if you look carefully enough, there's always clues there, whether it's a little bit of hyperostosis at the lip where it's attached, a little bit of vascularity that it's bringing from the dural attachment into the tumor, whether it's a dural tail extending along the margins of the internal acoustic meatus rather than along the nerve. All of these features usually let you get to the right diagnosis. And clearly this is really important because surgical approach is going to be different. Whether you're expecting the hearing to be spared or not is going to be different. Rate of recurrence is going to be different as well.
Excellent. So I think that's all we've got written here, Gaylord. So there are, of course, a whole bunch of practice cases that come out the end of your course in which you actually hide quite a few other pathologies. So rather than testing everybody on what you've just taught them, you sneak in
I
some new
do.
ones.
Very
Yeah. I
sneaky.
can only assume you wanted to keep people on their toes or perhaps just alienate them. I don't know.
I hope not alienate. I think the thing that most educational material in radiology gets wrong is that it forgets that patients don't present with a known category of disease.
Hmm.
And so if your learning pathway is just on tumors and the only thing you talk about is tumors, then patients don't turn up with a known tumor. They turn up with a lump that looks
Yeah, yeah.
like a tumor. And so the differential is at least as important as the content. So mimics, yep, unusual things that might lead you to say something silly or important, they're really crucial.
Yeah. No, it's a lot of extra fun at the end of the course. I don't want to spoil it for people, but there is one case of HOD, hypertrophic olivary degeneration, in the practice sets at the end. And I actually reported a case just
Mhm.
recently that had T2 hyperintense unilateral enlargement of the medullary olive, but there was no evidence on MRI of any prior insult in the triangle of whatever it's called, Guillain
Gillian and
Morellet. Yeah,
Morellet.
the dentato-rubric pathway. Both
Yeah.
of them are hard to say. And the clinical presentation was not palatal myoclonus or anything that's described in HOD anyway. I think it was hearing loss in this case. I suspect it's not a case of HOD, but I wonder, can you get HOD and not see a lesion elsewhere in that pathway?
I don't think I've seen a case like that, but I don't think MR is perfect. So
Mm,
I reckon it's possible that you have a small area of gliosis or
yeah.
damage that you wouldn't image. But in that context, I think you'd have to be more suspicious of it being something else and do more close follow up, right?
Yeah, so my conclusion was, describe the area of T2 hyperintensity and then said no diffusion restriction or enhancement to suggest high grade tumor. There are no other lesions to suggest demyelinating disease. There's no evidence of a lesion in the, olivary rubro tract or whatever it is. So I just kind of left it as there's no
Yeah.
other these other things to tell us what it is. And I guess low grade glioma is kind of like the default backup. But I guess follow up will be the answer for that patient.
Follow up will give you the actual, the first case of HOD that I saw as a registrar, I got extremely excited about because I don't remember the details of whether it was a cavernoma or a stroke or something.
Mm.
but they didn't give me the full clinical information of whether he had palatal myoclonus. And so I actually called up the patient and I asked him whether he had palatal myoclonus. And he's like, what do you mean? Like I said, does your soft palate like twitch or vibrate? And he's like, oh, I don't know. And I said, well, can you go have a look? So he went to the mirror and had a look and then came back and said, I don't think so. So, okay, thank you.
I thought you were going to say he was like, he had this wavering voice. It was like, yes, it does. All right, I think that's time to wrap this episode up, actually, Gaillard. We've made it to the end here. So people can find your course on posterior fossa tumours and the 3 other earlier brain tumour courses in the series over on our website. The website is, let me just look it up here, it's radiopedia.org. Interesting. But hopefully people manage to track that down. Maybe Google it. Maybe it'll come up. Who knows? So yes, head over to the website and find the course. It's free for Radiopedia, all access pass holders, and in low and middle income countries. And as always, Frank, I'll ask you to say how people can get in contact with us.
Well, you can email us at podcast@radiopedia.org with any ideas and or feedback. And you can join the Radiopedia community chat by visiting radiopedia.org/community.
Yes, and I've got a recent little review that we received on our podcast here to read out, Gaillard. So the review says, absolutely amazing podcast series with an exclamation mark. This is fantastic for radiologists, easy to listen anywhere. I love how the experts share their gems. I love even more the chit-chat between Frank and Andrew. Keep it going forever, guys, please. And that's from Dr. Mahmood in the UK.
Well, thank you, Dr. Mahmood. Forever is a long time, but we'll do our best. Can't speak for Dixon, though, but I have to say that having this reason to catch up regularly and just chat is really fun. So enjoy doing it. Keep the feedback coming. If someone can say something nice about my hair, that would be good.
That's good. Yeah. So that's a reference to the last episode, I think, when we were talking about my hair. He's going to do this every episode from now on until he receives a comment about his beautiful looking locks. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all access pass to our online courses conference. You get access to all 4 of Frank's brain tumor learning pathways, plus the future 27 courses that he's going to release about other brain tumors. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle income countries.
And Radiopedia 2025 is coming up in July, Dixon.
I know.
Don't forget. You haven't forgotten.
I haven't forgotten. I have a constant reminder in my brain every time I wake up. Oh, conference, better get going.
The program does look amazing. I'm hosting a neuroradiology workshop with Lee Al-Hali. And Dixon, you're hosting an MSK workshop with Chris Newman. So it's going to be fun.
Yes, very much looking forward to it. We're putting together all the cases at the moment. So we're doing the workshop slightly differently this year in that we have lots of radiologists submitting cases for the workshops, and they're going to record them. And then the people who are hosting the workshop are going to kind of do a little bit of a react to kind of setup. So I think there'll be probably more cases. Maybe the workshop will be a bit longer, bit more interactive, a few more faces than previous years. So it should be amazing, and everyone will be present in the live chat as well during it. So I'm looking forward to it very much. And what else can people do to help us out, Frank?
And you can also help us out by leaving us a 5-star review in the podcast app of your choosing.
Yep, just like Dr. Mahmood did. More than happy to read them out. People have asked, are we doing another like hostful podcast episode, Gaillard? But I think what's happened with the podcast is we've kind of evolved to the point where the intro and the outro in our normal episodes is pretty much like a hostful. We pretty much talk about anything we feel like. It doesn't have to be directly related to the topic. We're incorporating feedback and things into the outros as well. So really what we do in those hostfuls, or what we originally did in the hostfuls, we're kind of just doing episode to episode now. So we probably won't do them, but maybe we will one day if we feel inspired. But pretty much every episode is a hostful.
Full of hosts.
Full of hosts. And we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
Stay rad and go and get Gaillard's new brain tumor course. Bye.